Now, when we're thinking about assessment in hypothermia, really we're looking at two things. The first is the degree of hypothermia, that is what the patient's core temperature actually is. And the other important thing that will influence treatment, or can influence treatment, is the duration of the hypothermia. How long has the patient been hypothermic for? First of all, the degree. Now, actually, just to go back a bit, people can classify hypothermia in lots of different ways, but I'm going to classify it according to degree. And what we're going to do is say a mild case of hypothermia is where the body temperature is 35 to 32 degrees centigrade. Now, mild hypothermia is not to say trivial or inconsequential hypothermia, because even if someone's body temperature goes down to 32.5 or 33, that is a potentially life-threatening condition. And certainly with a temperature of 32, depending on how they're treated, that is potentially life-threatening. But we say if someone has a mild degree of hypothermia, if the temperature is 35 to 32 degrees centigrade. Now, a moderate hypothermia we would describe as 32 down to 28 degrees centigrade. That would be moderate. But again, moderate is a slightly misleading term because someone with what we've just classified as a moderate hypothermia, 32 to 28 degrees centigrade, it is certainly a life-threatening condition. A severe hypothermia we can define as any temperature below 28 degrees centigrade, and that certainly is severe, very, very dangerous, very life-threatening, below that level. Now, the duration, we normally say that short duration or an acute onset hypothermia is one which has been in existence for less than 12 hours, when the patient has been hypothermic for less than 12 hours. And that an insidious onset hypothermia, a longer term hypothermia, the patient has been hypothermic for more than 12 hours. Now, the reason this is significant is that if a hypothermia persists for over 12 hours, then the patient normally has a greater degree of cold-induced diuresis. They'll have lost a lot of body fluids. And there may well be cold edema. Some of the fluids from the blood will have gone into the tissue fluids. So over 12 hours, what it actually means is the patients are likely to be hypovolemic. There's likely to be a lower blood volume. And with that can go a disturbance in electrolytes. So over 12 hours, more likely to have hemodynamic and electrolyte imbalance. Under 12 hours, that may be less of a problem. So we've talked about degree in terms of temperature, duration in terms of hours. We're now going to think about the clinical features of hypothermia. Now, do you remember that all biochemistry depends on enzymes? Enzymes catalyse all biochemical reactions and therefore give rise to the physiology of the cell. And enzymes are very temperature specific. They only work at very specific temperatures. And the enzymes in the body, of course, are designed to operate at around about 37 degrees centigrade. So as body temperature drops, enzymic activity also drops. There's a reduction in enzymic activity. All the biochemistry in the cell starts working more slowly. And as well as that, enzymic activity and therefore biochemical activity becomes progressively disordered. This means there's a reduction in global physiological function. So it's going to affect the heart, it's going to affect the brain, it's going to affect the muscles. So the clinical features of hypothermia ultimately are explicable in these biochemical terms. But first let's think about what happens when people are cool, not when they're hypothermic, just when they're cooling down. Maybe the body temperature dropped below 36, maybe they're 35.5 or something like that. And we've already covered this really, you know, the skin is pale and cold because of the peripheral vasoconstriction. And the muscles don't work properly. Have you ever tried tying your shoelaces when you've got cold hands? It is virtually impossible. Cold muscles don't work very effectively. And you notice the muscles at the periphery first. Hand muscles are a good example. Arm muscles, because they're at the periphery, therefore there is a peripheral vasoconstriction which has reduced the blood supply to these muscles. Of course, the shivering, thermogenesis. Piloerection means that you get these goose pimples. There's contraction of the hair erector muscles in order to try and increase the boundary layer to insulate the body with air which is trapped near the surface of the body. Remember, air is a good insulator of heat, so that's a good idea if that can happen. And there's also an increased heart rate and there's an increased respiratory rate. Now, the increased heart rate, we'll see why this happens in a minute, but one way to think about it is that the blood transports heat round about the body, and if that's going more quickly, then more heat can be transported to vital organs. But we'll see in a minute that the faster heart rate and the faster respirations is explicable in terms of the activity of the sympathetic nervous system. So this is why we get the clinical features of hypothermia, and this is what happens when we're cold. We're going to think now about the clinical features of mild hypothermia. And remember, any time the core temperature drops below 35, the patient is hypothermic. Now, mild hypothermia is not really a very accurate descriptive term, because many people whose body temperature drops down to 32 degrees centigrade die. It is a life-threatening condition. So this is mild in the sense that the body temperature is round about 32 to 35 degrees centigrade, not mild in that this is not a potentially serious condition. It is a potentially serious condition. Now, even with a body temperature of 35 degrees centigrade, mental function will decline. The enzymes in the brain are not working properly. Therefore, the neurons are not working properly. Therefore, mental function decreases. And even at a temperature of 35 degrees centigrade, someone can probably have great difficulty adding up 4 and 4 or 6 and 2, or, it's very simple arithmetic. They might find that difficult. In fact, this is a useful test to see if someone's hypothermic. If someone's mind is thinking clearly and crisply, and they're able to do things like basic mental arithmetic, they're probably not hypothermic. And as the body temperature decreases, the patient can become increasingly confused and start behaving in an inappropriate manner. This is a problem when people are out on the hills, for example. They might become hypothermic and then start making irrational decisions. And the irrational decisions means that they're exposed to more cold weather or more wet, and they become more hypothermic. And as the temperature carries on dropping, there will be a decrease in the level of consciousness, and the patient will become drowsy. And this will be accompanied by decreased generalized motor function. Now, the clinical features of mild hypothermia can largely be explained in terms of the hypothalamus or the hypothalamic mediated attempted sympathetic compensation. Now, when the blood going through the hypothalamus cools down, this is detected, and the hypothalamus initiates activity of the sympathetic nervous system. Remember, the hypothalamus is contains the thermoregulatory centre. It contains many homeostatic neuronal clusters or nuclei. And one of the things it does is it controls body temperature. Remember, the hypothalamus is below the thalamus in the brain. It's just above the pituitary gland, actually. So when the blood going through the hypothalamus is cooler, the hypothalamus responds by initiating sympathetic responses, a sympathetic compensation. In other words, it's saying the body temperature is too cold, let's get it back up again. And this is why we shiver. So shivering is most intense at about 35, 34, 33 degrees centigrade. If someone's body temperature is around about that range, they'll be shivering really quite intensely. Now, when you get down to 32 degrees centigrade, they can still be shivering. But anything below 32 degrees centigrade, for reasons we'll see in a minute, there won't be shivering. So really, when you're assessing someone who's hypothermic, if they're shivering intensely, that's probably a good sign because it means their body temperature is probably above 32 degrees centigrade. So a lot of shivering to generate heat. The person feels incredibly cold. If the body temperature, if someone's just becoming hypothermic, 35, 34, 33 degrees centigrade, they feel very, very cold. They feel horribly cold. The sympathetic nervous system brings about quite profound peripheral vasoconstriction. Remember, blood vessels dilate when they are not neuronally stimulated. Well, peripheral blood vessels do anyway. So the sympathetic stimulation will cause the blood vessels to close down. Peripheral vasoconstriction. Now, if all the peripheral blood vessels are closed down, can you see that means there's more fluid, a greater blood volume in the core of the body? And this means that actually the blood volume is too large for the amount of vasculature it is circulating around at the time, because the person is peripherally vasoconstricted. So what the body does is it excretes water to reduce blood volume. That's why when it's cold, you need to pass urine more frequently, because you get a cold-induced diuresis. Later on, when people are very hypothermic, they can become oligureic or anureic. But again, with the mild hypothermia, the cold-induced diuresis. Now, because they're peripherally vasoconstricted, there's a tachycardia and there's an increase in blood pressure. Hard to say exactly why these come about, but you'll recognise them as sympathetic responses. It's consistent with the generalised attempted sympathetic compensation. There's also more rapid breathing, and initially the blood glucose levels will go up. There'll be a hyperglycemia. This is because the sympathetic nervous system stimulates the release of adrenaline from the adrenal gland, from the adrenal medulla. And the adrenaline will cause blood glucose levels to rise. And as well as blood glucose levels rising, the levels of free fatty acids in the blood also rise. And again, these things both make sense because they provide fuel for shivering thermogenesis and non-shivering thermogenesis. Both fatty acids and glucose are a fuel for that. So all of these mechanisms will start to bring the body temperature back up, unless heat loss, of course, exceeds the ability of the body's thermoregulatory homeostatic mechanisms to compensate. Now, as the hypothermia progresses, as the body temperature goes down to maybe 32 degrees centigrade, then the blood flowing through the hypothalamus is going to be at that temperature. And the neuronal function of the hypothalamus itself depends on the enzymes which are in the neuronal cells of the hypothalamus. So as the body temperature drops, the hypothalamus itself is going to stop functioning effectively. This means that the hypothalamus is unable to stimulate the sympathetic compensation, which is bringing body temperature back up to normal. So the hypothalamus is unable to work as the body temperature continues to reduce. This means the hypothalamus is no longer able to stimulate shivering. It's no longer able to stimulate peripheral vasoconstriction. And what this means is that the body loses its compensatory mechanisms. So as the body temperature falls, well, we already know that metabolic rate drops with reduction in temperature, so there's a reduction in thermogenesis from metabolic rate, and there is a loss of the normal protective compensatory systems. This is why hypothermia can become a downward vicious spiral. Now, we said before that the blood vessels will close down as a result of sympathetic stimulation. But when the hypothalamus, because it's hypothermic itself, is no longer able to generate sympathetic stimulation, then the blood vessels will relax. The peripheral blood vessels will relax because they're not being stimulated. And when the peripheral blood vessels relax, they will dilate. This means that you can actually get a peripheral vasodilation in someone who is hypothermic when the body temperature goes down below 33, 32 degrees centigrade. And how warm someone feels depends on the temperature of the blood flowing through their dermis, because the thermal receptors are located in the dermis. So when people's body temperature drops a lot, they can actually feel quite pleasantly warm because they've become peripherally vasodilated. Of course, because the blood is near the surface of the body, way more heat will be lost, and the development of the hypothermia will accelerate. But for this period of time, the person can look a quite nice rosy colour, and what's probably more dangerous is they can feel warm. Therefore, they're losing heat. And in fact, some people who become hypothermic feel so warm they start taking clothes off, which again accelerates the rate of hypothermia. So when the sympathetic when the hypothalamic mediated sympathetic compensatory mechanisms fail, the person is in really quite serious danger. Now, what we're describing here as a moderate hypothermia is life-threatening when the temperature drops below 32 degrees centigrade down as far as 28 degrees centigrade. And as we've already seen, below 32 degrees centigrade, the hypothalamus is not working properly and there's a loss of the sympathetic compensations. So the patient won't be shivering. The patient can be vasodilated, and they can also be bradycardic. The conducting system within the heart doesn't work properly when it's cold, and so the impulse is not transmitted through the heart. Do you remember the impulse that's generated at the sinoatrial node? Goes through the internodal tracts to the atrioventricular node, down the atrioventricular bundle of His, into the right and left bundle branches, and into the Purkinje fibres. The transmission through this conducting pathway is slowed down, so the patient will become bradycardic. And because they're vasodilated and because they're bradycardic, they're going to become hypotensive. Because, again, this makes physiological sense because blood pressure is cardiac output times peripheral resistance. And the patient's bradycardic, and there's a loss of peripheral resistance because of the vasodilation. Now, early on in the development of hypothermia, the reflexes are actually quite brisk. But as the hypothermia deepens, there is a loss of reflexes. So the pupils of the eye dilate. The pupil constricting reflex doesn't work properly. And because the patient is hypotensive, there can be reduced perfusion of the kidneys, resulting in possible renal failure, which is a complication of hypothermia. The enzymes in the muscle cells aren't working properly, so the muscle cells don't contract properly, and the muscles become stiff and rigid. And because the brain is working or trying to work outside its normal physiological parameters, there's a risk of fitting, a risk of convulsions. In fact, any time brain tissue is insulted, there is a risk of convulsions. So when the brain is too hot, that's insulting the brain tissue, there's a risk of convulsions. When the brain is too cold, again, that is an insult to the brain, and there's a risk that they'll be fitting. There's well-recognised, well-described ECG changes that can occur in hypothermia. I'm not going to go into them, but there are ECG changes. And there can be disorders in the way that blood clots. Normally, actually, when someone becomes hypothermic, the blood clots more readily. There can be excessive clotting of blood. Of course, there's progressive reduction in consciousness, and the patient can become, well, at lower temperatures, the patients will be essentially unconscious. But significant reductions in the level of consciousness in moderate hypothermia. And over time, well, I've already said there's a diuresis over time, so the blood volume drops for that reason. And over time, there's the development of edema. Now, as the tissues become hypoxic, they're still going to be metabolizing to a degree, and there will be anaerobic metabolism in many tissues of the body. If there's anaerobic metabolism in the tissues of the body, what waste substance will be produced as a result of anaerobic metabolism? Well, the waste substance produced, you probably remember, is lactic acid. This is obviously acidic. And the capillaries try and compensate for the tissue hypoxia by dilating. And as the capillaries dilate, they become more leaky. So you get accumulation of tissue fluid over time in hypothermia, and the patients become edematous. This, of course, further reduces the blood volume. It further reduces the intravascular volume. And there's also a risk of cardiac arrhythmias. Initially, there can be ventricular ectopic beats. Premature ventricular contractions is they're sometimes called, but I still call them ventricular ectopic beats. There's a risk of other arrhythmias such as atrial fibrillation, and of course there's a risk of ventricular fibrillation. And this is probably, almost certainly, the main cause of death in hypothermic patients. There's a ventricular fibrillation. The heart muscle is going to become hypoxic. In fact, in hypothermia, all the tissues of the body become hypoxic, because there is a shift to the left in what physiologists call the oxygen dissociation curve. What this means in practice is it becomes much harder for any oxygen that is in the blood to diffuse, to leave that hemoglobin, to diffuse into the tissues. So the tissues become progressively hypoxic, therefore the myocardium becomes hypoxic, therefore it is at a greater risk of fibrillating. And of course, as well as being hypoxic, it's hypothermic, so it's receiving at least two insults. Now, as hypothermia becomes severe or profound, the temperature might drop, say, below 29, 28 degrees centigrade. Then at these temperature levels, the brain will essentially not be functioning well enough to generate consciousness, and the patient will be comatose. They will be unconscious at these levels. The pulse will be very slow and very weak, as will the respirations. Everything has slowed down quite profoundly by these levels. And in fact, the pulse and respirations may not be detectable. And in fact, this condition can mimic death. The patient can appear to be dead. But as we'll see later on when we discuss treatments, it's very important not to assume the patient is dead. Because hypothermia, if you like, is a differential diagnosis for death. You can examine a dead patient and a hypothermic patient, and they can really appear much the same. And even quite senior people are sometimes caught out by this. They examine a patient who's hypothermic and pronounce them to be dead. But actually they don't know whether they're dead or not, because it's very difficult to tell the difference between hypothermia and death. Hypothermia can mimic death. So we don't declare anyone dead until we've warmed them up first. The saying is, no one's dead until they're warm and dead. But we'll come on to that later on. But remember, never assume someone is dead when they're hypothermic. You must warm them up first to make sure that they're actually dead. Because when you warm people up, they can appear to come back to life as the hypothermia reverses, as long as it's well managed. Patients will also be very acidotic. Remember, we said that there's a change in the way that the blood is able to give up oxygen to the tissues. The tissues will all be hypoxic, and the patient will develop an acidosis. The lactic acid will build up due to anaerobic metabolism. And as well as that, because the liver is cold, the liver is no longer able to biochemically degrade these acids. And in fact, at any temperatures below 28 degrees centigrade, the liver is essentially not functioning biochemically at all. So acids that are generated can't be metabolized by the liver, and they will accumulate in the body. Now, as we've said, a hypothermia of 32 degrees centigrade is life-threatening. But if the temperature continues to go down 26, 27 degrees centigrade, there's a risk of really quite spontaneous, life-threatening arrhythmias, ventricular fibrillation. And if the patient doesn't go into cardiac arrest, they'll become progressively cyanosed. And if there's been a long time that the hypothermia has developed over, there'll be edematous. By 24 degrees centigrade, the respirations will have stopped, and by 20 degrees centigrade, the heart will have stopped, if they haven't died before that. So that concludes our look at clinical features.